A very good evening, respected.
Just one minute. Now you can start.
Okay. A very good evening, respected faculty and distinguished. On behalf of entire team Gennova, I, Dr. Supriya Pol, welcome you all to this national workshop, No Thrombosis. Well, we all know that stroke continues to be a major contributor of morbidity and mortality, which is posing a significant clinical and public health challenge across all the healthcare setting. Well, this initiative basically focuses on real-world clinical insight through case-based discussions. Now, with that note, it is my absolute honor to introduce our today's distinguished faculty. We have Dr. Subhash Kaul sir joining us as course director. Well, sir is a senior consultant in KIMS Hospital. Sir has more than over 40 years of clinical, academic, and research experience. Sir also has a stroke fellowship from Baltimore, USA. He is also a fellow of the Royal College of Physicians, also American Academy of Neurology, American Heart Association, and Stroke Association. Well, sir has more expertise with respect to stroke, cerebrovascular disorder, clinical neurology, neurological education, and also with clinical research. Well, sir has more than 105 publications to his name and also contributed to more than 20 book chapters. Sir has delivered over 300 invited lectures and orations. He is also a principal investigator for multiple national, international, and also ICMR-funded clinical trials. Well, sir is also a recipient of Telangana State Teacher Award. Sir, coming to his academic contribution, sir has over 30 years of teaching experience in neurology, and sir has trained more than 50 DM neurology students. Well, talking about his leadership role, sir has also served as past president of Indian Academy of Neurology, Indian Stroke Association, of Andhra Pradesh Neurology Association too. We welcome you, sir.
Thank you.
Moving on, we have our first speaker, Dr. Manoj Vasireddy, sir. Well, sir is a consultant interventional neurologist with more than 10 years of experience in pediatrics, neurology, and neurointervention. Sir has done his DM neurology from St. John's Medical College, Bangalore. He has also followed a postdoctoral fellowship in stroke and neurointervention from Kolkata. Well, talking about sir's expertise, he has a wide experience with respect to stroke, neurointervention, mechanical thrombectomy, carotid artery stenting, aneurysm coiling, cerebral and spinal angiography, cerebral venous sinus stenting, neuromuscular disorder, epilepsy, and many more. Talking about sir achievement, sir specializes in endovascular treatment of stroke and neurovascular disorders. Talking about his academic contribution, sir is actively involved in mentoring junior clinicians in neurointervention techniques and promoting patients' education and public health awareness. Talking about his leadership roles, sir leads stroke care services at Sri Sri Holistic Hospitals and he mentors junior staff there. We welcome you, sir. Moving on with our second speaker, we have Dr. Anita Kotha ma'am, who is a senior consultant neurophysician at Star Hospital, Nanakramguda, Hyderabad. Ma'am has an expertise in epilepsy, movement disorder, acute stroke management, pre-surgical epilepsy evaluation, deep brain stimulation programming, and IV thrombolysis. Talking about ma'am's achievement, ma'am has performed over 500 IV thrombolysis procedures for acute stroke and more than 1,000 therapeutic lumbar punctures. Ma'am also has been a university gold medalist during her MBBS time in pharmacology. Talking about ma'am's academic contribution, she is DM and DNB dissertation researcher, associate teacher consultant for DM neurology, DMB neurology, presenter at national and international conferences also. Ma'am has been a founder and chief consultant, Brain and Spine Neuroclinic, Hyderabad, and she is also an active member of IAN and IMA. We welcome you, ma'am. With that, I would now like to hand over the session to Dr. Subhash Kaul, sir, to set up the context. Over to you, sir.
Okay, thank you very much. I think we have been doing this session for more than 2 years now. And the highlights of this No Thrombosis series is that we discuss cases in this. And I think the teaching and the learning which comes from case can never be matched by any other method. When we read the knowledge and guidelines based on cohorts of patients. which is an average of number of patients, thousands of patients. But when patients come to us, they don't come to us as cohorts. They don't come to us as average of 1,000 patients. They come individually. And each patient is different. Each patient's genetics is different. Each patient's response to treatment is different. Each patient's clinical scenario is different. So therefore, if we have to really hone our skills as a neurologist, we have to learn case by case by case. And there is a combination of this. I mean, like from 7 notes, you can create millions of songs. Same is true about patients also. From the same stroke, there'll be thousands of present. There'll be subtle differences. There'll be different cases. And in each scenario, we have to take an individual decision which goes sometimes beyond the guidelines. Sometimes we even have to break the guidelines. So with that, I think I thank Gennova for making this platform and the team Gennova. And it's my pleasure first to invite Dr. Manoj Vasi Reddy, who is an interventional neurologist and has already been introduced. So I request Manoj to go ahead with his case.
Thank you, sir. There is something wrong with I think, the camera, but I will try to share my screen directly. Please let me know if you're able to hear me and see my screen, sir. The moderators. Thank you very much. Are you able to see my screen, please?
Yes, sir. It is visible. So for the camera, you can just, I think the flap is
No,
closed.
the flap is on, madam, and I have used it also, but the app is. But let me please start my presentation.
But don't worry about that because your
Yes.
voice is audible. That's important.
Yes.
Go ahead with the presentation.
So,
but you can make it a
sir,
slideshow if possible.
Yes, sir, and thank you for giving me this opportunity to present. I will structure my talk with 2 cases. There are certain contrasting points in both these cases, and then I will discuss what I want to convey about these cases, and then I will be open to take questions. Thank you. The first case is a 64-year-old female, diabetic, hypertensive, AF. She came with right-sided weakness, aphasia, left gaze. She came in 5 hours duration with a high NHS. And this was her scan. It was a left MCA occlusion. This was her angio. There was the left MCA infarct with the CT angio showing left MCA occlusion. This is after taking up for thrombectomy. There was a left MCA occlusion, and then after recanalization. What I want to show in this slide is that the ACA territory, the perfusion is good. We can see a good parenchymal blush. But even after recanalization in this MCA territory, the vessels are recanalized, but the capillary perfusion and parenchymal blush is not well seen. This is a lateral view of that. Again, in this region, the parenchymal blush is not well seen, but in the ACA territory, it is well seen, even after recanalization. This is the other side of the normal side, in the right side, with good capillary blush. This image I have put for comparison, and this is her post-operative CT. So despite a good recanalization, which has happened in a decent time, and she presented to us in a decent time. We have counseled and taken up for the procedure. Unfortunately, her entire MCA territory, we were not able to salvage it, and her post-operative recovery in that sense was very bad. She was later sent to a rehab, but we could not get a good clinical outcome from her. This is a second case. This was done by my colleague, 56-year-old male, diabetic, came with common posterior circulation symptoms, which began with imbalance while walking, quickly followed by drowsiness. He came in a very good time from nearby. He was drowsy with a poor GCS at presentation. This was his MRI. There was no established infarct at the time, even though patient was clinically drowsy and he was not bad. This is his CT angio.
First of all, please just 1 minute, memory.
These are his images. We can see non-opacification of basilar trunk above the. After the formation of the basilar trunk proximally, there was non-opacification. Mechanical thrombectomy was done. This was his first flow after mechanical thrombectomy. After this, the major vessels appear to be recanalized. The basilar trunk with posterior cerebral arteries and even the scar are visible. But similar to the previous case, the parenchymal blush around the brainstem was not seen. The capillary blush is not seen. This is the next one after giving 2 mg of intraarterial tenecteplase for this patient. We can see better opacification of all the arteries, the basilar trunk, the scar, and even the capillaries, including the perforators. This was his post-operative CT. There are some infarcts in the thalamus and medial temporal and occipital, but this patient came out well preserved and he made a good clinical recovery. So then I would like to proceed with my talk. Mechanical thrombectomy, even though it is a standard guideline of practice now, it at best gives us macrovascular success. And a proportion of the patients with good TK3 or TK2B2C recanalization still continue to go and have a poor 90-day functional outcome. There are 2 concepts in this. It's futile recanalization or the no reflow phenomenon. Futile recanalization means there is a structural success of mechanical thrombectomy by obtaining revascularization, but there is a functional failure because the downstream brain tissue does not recover from the stroke. This happens because there is failure of microcirculatory tissue level perfusion. This is the ASA article from 2023 describing no reflow phenomenon. It describes the causes of no reflow phenomenon. Most significant of these is microvascular occlusions due to microthrombi. Though we are able to retrieve the clot from the major vessels like the basilar, carotids, and MCA and obtain macrovascular success, microvascular occlusions are not accessible by whatever standard devices and MT techniques we have. Other than microvascular thrombi, there is also pericyte contraction due to ischemia, which is caused by the stroke, oxidative stress, and pericyte contraction, along with endothelial and astrocyte edema of the blood vessels, which cause narrowing of the already small capillary lumen. It also triggers a white blood cell reaction, which causes leukocyte adhesion, neutrophils aggregation, and which further aggravates the stagnation of the microvascular circulation. All these phenomena prevent adequate blood supply at the microcirculatory level to the brain tissue. What are the imaging features which we can identify that this no reflow phenomenon or futile recanalization can occur immediately after the mechanical thrombectomy procedure inside the cath lab. There is absence of parenchymal blush, which is the most important imaging marker which we have seen in the first case. There is prolonged microvascular transit time. There are certain values which are given like 8 seconds for the IC and 15 seconds for the basilar circulation, the posterior circulation. There is delayed venous outflow during the angiography. And there is an index, modified capillary index score, in which the ischemic territory is divided into 3 equal parts. And based on the presence or absence of the capillary blush, it is scored as 0 to 1, and any score less than 2 indicates a poor prognosis. But still, the most important imaging marker of this will still be the absence of parenchymal blush, with which we can obtain without advanced technology in the cath lab. What is the literature saying about using intra-arterial thrombolytics? There were 2 trials with Altiplace. One is the CHOICE trial and the CHOICE 2 trial. The CHOICE trial was started during the COVID period, and it was concluded prematurely because of the COVID limitations, and the CHOICE 2 trial was concluded in 2026. It used 0.225 mg per kg with a maximum of 20 mg of Altiplace over 15 minutes intra-arterially after obtaining TK3 recanalization in MT. Both were done during the early window. The primary outcome of MRS 0 to 1 was significantly high, but in the CHOICE 2 trial, the 90-day mortality was high in the patients where Altiplace was given intra-arterially. There was no statistical difference in the symptomatic IC bleeding. Next, if we go to tenecteplase, 2 trials were done, both of them in China. The DATE trial was done in 2025 and the ANGEL TNK trial. The DATE trial was done mostly to assess this safety of giving intra-arterial tenecteplase after mechanical thrombectomy and achieving at least MTK2B recanalization. They have given in the doses of 0.03125 per kg, 0.0625 per kg, and 0.125 mg per kg doses. They found that doses up to 0.0625 mg per kg or 2 mg was safe, and doses above that significantly increased the rate of symptomatic intracranial bleeding. Also, the primary outcome of MRS 0 to 1 was significantly better in patients in whom tenecteplase was given intra-arterially after proper recanalization in mechanical thrombectomy. Next trial is the ANGEL TNK trial. This again was done in most of the centers are in China and 1 or 2 centers were in Australia. In this, the primary outcome was achieving a low MRS of 0 to 1 after giving tenecteplase intra-arterially after achieving MTK2B, at least recanalization after the procedure. They did 256 patients, and the primary outcome was significantly better in patients who received intra-arterial tenecteplase after achieving recanalization. The DATE trial was done in patients only in the early window, less than 4.5 hours, but the ANGEL TNK trial was done even in the late window, 4.5 to 24 hours. The mortality of patients in the late window was quite high, 21% of patients who received intra-arterial tenecteplase, but compared to controls who did not receive and presented in the late window, it was not statistically high. Symptomatic intracranial bleeding was comparable and it was not statistically high by giving intra-arterial tenecteplase. Advantages of tenecteplase over altiplase is that there is fibrin specificity. It acts only on fibrin, and the half-life is more because plasminogen activator inhibitor is sustained, and delivery is easy. It is given as a single bolus compared to altiplase with 1 hour infusion. The conclusion is that despite achieving proper recanalization in thrombectomy, we have to be vigilant for certain signs which may indicate a bad clinical outcome despite good recanalization. And maybe we can use intraarterial lytics, alteplase or tenecteplase for that fact, to improve the clinical outcome in these patients. Thank you, sir, and listeners, if there are any questions.
Yeah, I think that's a very good presentation where you are highlighting the advantage of giving intraarterial tenecteplase, as a matter of fact, in preference to alteplase after these mechanical thrombectomy. Now, as per your suggestion and based on the data, should it be given to everybody who has undergone mechanical thrombectomy as a routine, or do you need to look for this lack of microvascular blush and only to that selected population? What is the suggestion from the literature?
Only to in the literature, they have given to everyone in their cohort who have taken and achieved macrovascular recanalization. But the ASA article also describes these signs which we have to look for, which indicate that these patients will have a poor clinical outcome. So because this is outside the guideline, I cannot comment what has to be done, but preferably if we can use this in patients who have these imaging signs of microvascular failure, maybe we can avoid unnecessary bleeding complications.
Yeah, that's true. People have been talking about it for the last 4-5 years now, but I think it has not yet come into the formal guidelines. Even in 2026 also, I don't think that it's already in guidelines as a routinely to be done.
It is not, sir. And the sad thing is that after using 2-3 mg, we have to discard the entire vial, and it is not useful to anyone practically. So that is one thing.
Yeah. No, but that's all right. But then that maybe if it becomes really approved and if more and more people do, then the companies can manufacture smaller vials for this purpose.
Yes.
You know, it is same what we used to give. We used to give many years ago intra-arterial therapy, and that time tenecteplase was not available, and we used to give alteplase. And for mechanical thrombectomy, most of the vial we used to throw. Only a small portion of it used to be given.
Yes.
So then they came out with small vials, 20 mg. So maybe same can be done by tenecteplase. But I think your point is extremely well taken, that we need to do very selective. Once you are spending so much of time, effort, energy, money, then the outcome is very important. And only fear is the bleeding, which doesn't seem to be statistically very significant, and that's a good thing to know.
Yes.
So I think that's a good presentation. The other thing is that when your the window period was same, the time at which it was done from the onset. How many hours first one and how
One
many
case
hours?
was 5
Was there
hours and
other
one case.
variables similar?
No, sir. One case was 5 hours and one case was 1 hour.
The first one and the second one.
Yes, sir. The first one was 5 hours and the second one was 1 hour. And most likely the patient did well because he came very
1 hour
early.
after this.
Yes.
No, that's also. So that also could be a variable. That's why I said.
Yes.
See, there's a difference between 5 hours and 1 hour, no?
Yes.
But you could catch him within 1 hour. So I think that's another message. That
Yes.
all these factors work together. It's not just one isolated factor. He was early, because that is why, if you see the first case, it was a very well-defined stroke, you can see. But in the second case, it was just evolving stroke.
Yes, sir.
So,
Yes.
so I think that was good. So time is really brain. But your point is very well taken. Thank you very much. Supriya, are there any questions in the chat box? Anybody is asking any questions or no?
Kalpita, can you help us with questions, if there are any?
If at all there are any.
Ma'am, currently there are no questions. If in the due course of time there are any questions, I'll let you
We'll
know.
take it at the end. Sure.
Yeah, if there are, for all the people who are attending this webinar, if there are any questions, please feel free to type them, and Manoj can answer it in end of the session. So I think thank you very much,
Thank you,
Dr.
sir.
Manoj, for
Thank you, sir.
giving us a new insight. And with that, it's my pleasure to invite Anita. Anita was my own student, and she was a very bright student. I remember that in Nizam's Institute, and I think over to you, Anita.
Thank you, sir. Thank you very much about nice words. Good evening, everyone. This is my small first presentation in this forum. So, can you see the slides? Still sharing. Trying to share. Can you see the slides, sir?
Not yet.
Not yet.
It is still showing sharing a window.
Ma'am, we can see the screen, ma'am, that you have shared, not the PPT, ma'am.
PPT, how can...
Ma'am, please open your PPT
You
in the
have to
background.
click.
Ma'am, I would request you to please open the PPT in the background, then go to share. There you
Okay.
will see an option of screen and application window. In the application window, that PPT will reflect, ma'am. Then you can click on the PPT and share.
Just don't know. Okay. Can I share the PPT with you so that you can...
Kalpita, help ma'am with the ID, no?
Yeah, I'll just drop in my email ID in the chat box. You can share it on that email. Done, ma'am. You can send it on this email.
One second.
Ma'am, let us know once you share, ma'am.
Have you shared the PPT? I think you're on mute, ma'am.
Can you see the screen?
Yes, Anita. Good.
Yeah.
But you can make it a slideshow.
Yes, sir. Yes, sir. Sure.
Yes, good.
Just going to present is a single case of progressive medullary stroke who progressed despite IV thrombolysis. This patient is a 45-year-old male who presented with 3.5 hours duration of acute onset of giddiness with vomiting, diplopia, and left-sided numbness and mild dysphagia. He had a history of old CVA versus TIA 5 years back, and the records were not available. He is a hypertensive, chronic smoker, not on any medication. His examination showed BP of 220 by 110. He was conscious, coherent. There was right gaze palsy with left gaze deviation, decreased sensation in the left upper and lower limb, and reduced gag reflex. So this was his initial MRI, where it showed diffusion image showed faint medullary infarct in the medial medulla with ADC reversal, and MR angio showed almost complete absent flow in the right vertebral artery till the confluence with the basilar artery, whereas left vertebral artery, basilar artery, and bilateral PCS were patent. And incidentally, he found to have right ICA occlusion with good collateral flow. So with this, he diagnosed with acute medullary with right vertebral artery occlusion, and then we went ahead with in window period of 3.5 hours. We went ahead with thrombolysis after initial stabilization and controlling his BP. He was thrombolized with 18 mg of tenectase IV. Till 8 hours of post thrombolysis, he was doing well, but post 8 hours, he had significant deterioration in neurological condition with new onset right hemiplegia, worsening dysarthria, dysphagia, and drowsiness, and developed horizontal gaze palsy, suggesting stroke in evolution and thrombus propagation. This was his follow-up imaging post 8 hours IV thrombolysis, where it showed diffusion showed well-established evolved infarct involving the pontomedullary junction with ADC reversal, and sorry, I could not videos I could not share, sir. Actually, videos. Yeah, I'll just show them. This was the CT angio. This was the CT angio at the same time where it showed basilar artery, distal basilar artery and right vertebral showed, where proximal basilar and vertebral artery occlusion was noted. So this shows, I think, probable recanalization of the right vertebral artery with distal vertebral artery and proximal basilar artery occlusion. Despite IV thrombolysis, with patent distal basilar artery and PCA flow was patent. So with this, we have considered for endovascular thrombectomy. I think I discussed this case with you also, sir, actually.
Yes.
There was, in view of recanalization of the right vertebral artery and patent distal basilar artery flow, the intervention team suggested not to intervene actually, because they thought that with the thrombectomy, the thrombus might embolize into the patent basilar artery and might lead to catastrophic basilar stroke with locked-in syndrome. And the same thing we have explained to the attenders. So they were also not keen after explaining this. So we did not do EVT for this patient. So meanwhile, patient had rapid deterioration in the sensorium and he had aspiration. We had to intubate and connect him to the ventilator. We continued with the conservative management with antiplatelets and heparin and statins. This angio was, so meanwhile he had mild improvement post 24 hours. He had mild improvement in the sensorium and there was mild improvement in the power, but still he continued to have apnea episodes with intermittent decerebrate posturing. So post 24 hours angio showed still the same as like post 8 hours of IV thrombolysis with the distal vertebral and basilar artery flow was not seen. These were his serial angios where this is MR angio with initial MR angio followed by 8 hours post IV thrombolysis CT angio. These were the 24 hours post thrombolysis angios. So luckily he had a further improvement in his sensorium despite not doing EVT. So he had improvement, consciousness improved and the gaze palsy is still persistent with, he had mild improvement in the power also. The right upper limb power was 2 and left upper limb and lower limb power was 3/5 with ataxia. So he had quadriparesis with more weakness on the right side post 48 hours IV thrombolysis. So he had bulbar weakness was persistent. He had continuous secretions and dysphagia was persistent. So we went ahead with tracheostomy and he had further improvement in the weak power. So we could wean him off from ventilator and oxygen. And in 1 week of post IVT, we could shift him to the room. In the room, when he was in the room, this is the clinical thing where the right gaze palsy has improved and power also has shown improvement with bilateral upper limb power almost 3+/5, but still continue more weakness on the right side. Lower limb power also improved to 2 to 3/5 power on the right side and 3+/5 power on the left side. So actually, this case, I still feel the endovascular thrombectomy could have resulted in further rapid improvement in the sensorium and bulbar weakness of this patient. So still this patient has persistent bulbar weakness, still on tracheostomy. It's almost 20 days of thrombolysis. So, I mean, the thing is we could have done endovascular thrombectomy, what I feel. So in posterior circulatory stroke, in this patient, he had mild symptoms followed by rapid deterioration, and there was progressive cranial extension of the thrombus with development of quadriparesis, dysphagia, and altered sensorium, which most of the case reports also showed the similar presentation with high mortality without prompt recognition. In this patient and most of the patients with the posterior circulatory stroke, they showed deterioration despite neurological deterioration despite IV thrombolysis. The factors which are associated with poor response include large thrombus burden, basilar artery involvement, severe atherosclerotic disease, delayed reperfusion, poor collateral circulation. Most of the factors in this patient also, I think these factors could have led to further deterioration despite giving IV thrombolysis. So I just want to give brief presentation about the timeline of the trials in endovascular thrombectomy in basilar artery occlusion and isolated vertebral artery occlusion. So the major RCTs like basics and best trials before 2022. These trials, basics trial and best trial, did not show any significant improvement when compared to medical management in post EVT. But the registry data suggested the use of EVT. But a significant improvement in EVT came after May 2022, where this attention Bavos trial, they have presented their results in European Registration Forum in May 2022, where they have shown significant functional improvement, functional outcome after EVT, even with the extended time window. Attention trial after within 12 hours of window, they have done EVT, whereas Bosch trial showed significant improvement when they have done 6 to 24 hours of procedure post stroke. So these studies supported thrombectomy in selected patients with basilar artery occlusion. However, patients with preserved basilar flow and isolated vertebral artery occlusion remains challenging, requiring individualized multidisciplinary decisions. So, coming to isolated vertebral artery occlusion, the only existing data till 2020 was BEST trial and some descriptive registry analysis of 42 cases from Chinese endovascular cohort. In BEST trial, subgroup analysis of 12 individuals with vertebral artery occlusion was enrolled. And in this trial, they seemed to have worse outcome with EVT than medical management. These results might have been confounded by loss of equipoise over the course of the trial, resulting in poor adherence to the ASCENT study treatment and reduced sample size due to the early termination of the study. And the next major study in isolated vertebral artery occlusion, EVT in isolated vertebral artery occlusion, is BRAVO study, where this study concluded that IV thrombolysis remains safe and effective first-line approach for isolated vertebral artery occlusion associated superior early neurological recovery and recanalization compared to conservative care. And this study revealed a paradoxical outcome for EVT in isolated vertebral artery occlusion. Despite significantly higher recanalization rates, EVT was associated with worse 3 months functional outcome and higher rates of early neurological deterioration. And the safety concerns regarding EVT in this population included a 6-fold increase in the symptomatic ICH compared to medical management. And the high rate of early neurological deterioration in the EVT group suggested that mechanical manipulation within the vertebral artery may cause snowplowing of the plaque into the vertebral artery perforators or trigger distal embolization into the basilar artery, transforming relatively stable vertebral artery occlusion into more severe basilar artery strokes. So patient selection is paramount. Subgroup analysis suggested that patient with moderate to severe deficits with NH score of more than 10 may still derive benefit from EVT, whereas those with milder symptoms do not. So, yeah, the key points are medullary infarction may initially present with subtle symptoms but can deteriorate rapidly. Neurological worsening after thrombolysis should raise suspicion of thrombus propagation. Patient with preserved basilar flow and isolated vertebral artery occlusion may remain challenging, requiring individualized multidisciplinary decisions. With this, I thank organizers and Subhash Kaul sir for giving this opportunity. If any questions, I'll just. Hello,
Yeah,
sir.
I know.
Sir.
Anita, I remember this patient. You
This
called me
patient.
also.
Yes, sir. Yes, sir.
And
So.
you know, the vertebral artery, there was a medullary infarction in this patient.
Yes, sir.
But there was no cerebellar infarction, was there? No.
There were no cerebellar infarctions.
It was pure
and medullary.
It was medial medullary.
Yes, sir.
Yeah. Yeah. Which part of the medulla? I think it was medial.
It was medial medullary, sir, initially. Right? Initial scan showed medial medullary, posterior-medial medullary. With probable, yes, this is the infarct. So this faint, it was very doubtful faint infarct, sir, initially. So mostly involving the medial.
And later on, it has increased in size.
And involved the pontomedullary.
Did it increase in size later on?
Yes, sir. It has increased in the size.
So.
And yes. Clinically also, there was gaze deviation was there, sir. So that suggests involvement of the PPRF. So mostly from beginning, he might have had some amount of medullary and pontomedullary junction involvement. Apart from medulla, but there were no cerebellar infarcts in this case. So mostly related to like vertebral artery territory only, but with progression, he might have had paramedian vessels also because of the basilar artery occlusion. Was also there. Yeah.
So you know, there are two things in this. One is what we think conceptually, and the second is what the trials show, because finally the proof comes from the trials.
Yes,
and conceptually, why would you intervene? You would intervene to prevent any further progression, because we are convinced that the source of the clot in this container is coming from the vertebral artery only, and we don't want any further clots to form. Therefore, conceptually, you would think of doing the intervention. But the trials which you have shown so far have not supported that. In fact, they have shown that the endovascular may do worse. Because one of the things in this intervention, people, what they often say is that if there is if there's a low NIHS, or if the patient is not having a very devastating thing, then it is sometimes better not to intervene, because it can cause further complications. And main challenge in the mortality is about the basilar artery stroke actually in this. Since the basilar artery was already well perfused, and since the initial infarct in the pons was not very big, that's why the interventionalists thought that maybe they will disturb this balance by doing.
Could it be the retrograde flow from the PCA, sir? The whatever the distal flow was seen in this scan could be the retrograde flow from the patent PCAs. I thought so. And the thing is,
it's possible.
Yeah.
It's possible.
Actually, initial NIHS was almost 3 to 4, but when he had deterioration, NIHS score almost it went up to 20, sir. So that is more than 10 actually. In the initially, I justified giving IV thrombolysis in the beginning initial presentation. But after deterioration, I thought because NIHS score has increased and there was initially the basilar occlusion was not seen except for that very proximal confluent level. The basilar artery thrombosis progression was there with the further involvement of the pons and pontomedullary junction. So that's what I think. With the because we could have, I mean, I think he might have improved because that is still in window period, no, sir. what if I see the patient, if somebody thrombolized the patient came in a state of deterioration to me. Like the second part, when if he comes to me for the first time, I could have gone for mechanical thrombectomy, I thought, sir.
What is the difference in the size of the infarct when he worsened?
Definitely, sir. He had a very faint infarct, which was we were very doubtful. Even radiologists didn't appreciate the infarct. Actually, this is the initial infarct. So with the progression,
and the second one.
Second one, I'll show you this. This is actually in the pontomedullary junction, sir. So this you see this.
This is the second or the first one?
This is the second one, sir. This is the second one.
First one you can't
almost, see. First, I'll show you. I'll just keep it side by side. Sir. Let me keep it side by side.
So
getting another. So this is the second one, sir. You can see this, no, sir? This is almost medial bilateral parameter.
And where is the first one? Where is the first one?
I'll show you the first. This is the first one, sir.
Now tell me one thing.
Sir.
When you give IV TPA, that time it was within how many hours? I mean, IV tenecteplase.
3.5 hours, sir.
And after how many hours the patient worsened from the stroke onset?
6 to 7 hours, sir. Post IV thrombolysis. Post IV thrombolysis, 6 to 7 hours, sir. It is within window period for mechanical thrombectomy.
No. Yeah. So are you saying that immediately after the IV TPA you should have gone for mechanical, or are you saying after he worsened he should have gone for mechanical?
At least after worsening,
what is your thought process?
Two things, sir. Yeah, as you said, immediately after IV thrombolysis, I could have gone for CT angio. I could have gone for CT angio even if the patient was stable. With the CT angio, I could have got an idea whether to go for mechanical thrombectomy. Because in this case, we did not do CT angio in this case. Sir. And at least after deterioration, because that was immediately we took him for the scan, which showed the evolved infarcts. So that is, I think that is like a second stroke.
But you had done the MR angio in the first place. MR angio you had done.
MR angio is there. Sir. This one is MR angio.
Yeah.
This one is MR angio.
MR angio had shown. And MR angio had shown there is a block.
There is at the origin of the basilar artery, at the confluence, there is a tight stenosis here, sir. We can see this.
And how much was when you give the TPA, I'm again saying TPA, when you gave the tenecteplase, how much was the NIHS at that time? 2 or 3?
NIHS was gaze palsy, left-sided numbness and mild dysphagia comes around 4, sir, 4-5. NIHS. Absolutely, he didn't have any other deficits except for the gaze palsy. And he was complaining of dysphagia and mild gag reflex was weak and left-sided numbness was there.
Yeah.
Power was good.
I think because one of the things is that we cannot see what is going to happen in future, right?
Yes, sir, yes.
This is a perennial debate. Until now also we don't have an answer. That should we do a mechanical thrombectomy in low NIHS patients? I mean, as of today also, most of the people will not do in low NIHS patients. They say that till NIHS is at least 6, they would not like to do mechanical thrombectomy because they're not sure about the outcome. So there's a rule of 6, they used to say, that the patient, that's in the anterior circulation, of course, that the aspect should be more than 6 and it should be done within 6 hours, and NIHS should be more than 6. Because what you think is sometimes that if the patient is having an NIHS of 3 or 4, if you intervene mechanically, maybe the patient will worsen and then you will say, so this is an ongoing debate. On the other hand, some people say that no, they should still do it. But there is no guarantee that the mechanical thrombectomy will succeed. Sometimes there can be disasters following.
Yes, sir.
I mean, that's why they were very reluctant. But I see your point, because it was in the same territory, and maybe if that clot was removed, then maybe they may not have progressed. So that thought is good. But I think the final result has to come from the trials only. But anyway, the good thing is that the patient is improving now. She has become conscious.
Yes,
There's a partial return of power also. And that return of power may be because of the circulation in that micro circulation, which Manoj said in the first presentation. As a matter of fact,
maybe
most of
thrombolysis might have helped in improving the microcirculation.
there is no doubt about it. There's no doubt about it that IV thrombolysis which you give, it works at the level of the microcapillaries. It does not work so much at the macro level. It works at the macro. So even though your vertebral artery per se was blocked and it remained blocked, but a lot of this drug pursues in the microcirculation, which you cannot see by angio. And that is the reason when you see the improvement after IV thrombolysis, it is counted not at 24 hours, it's counted at 3 months.
3 months.
As a matter of fact, if you look at original thrombolysis studies, at 24 hours, there was no difference between placebo and thrombolysis. The difference was seen after 3 months, because it takes for some time for patient to recover, and that recovery is because of the microcirculation also. That's also one of the factors in addition to. So I think I agree with your management, and I also agree with the question you have. And I think that question will probably be answered by the trial which you are talking. And maybe in future we'll know whether we should intervene or not. But then you have consulted all the interventionalists, and everybody was not in favor of intervening, right?
Yes, sir. Yes, sir. So some people thought we could have done EVT with the vertebral artery stenting. Still, I mean, we don't know, sir. Still, because patient has improvement. Again, they said like patient is improved. So the same thing. Like the not to intervene, the decision of not to intervene was good. Like
stenting also would be a dangerous thing in this situation, because then you have to remove the clot. First, you have to get a lumen, and then you have to put a stent, then double antiplatelet, then the risk of bleeding. So these are difficult questions. I think under the circumstances, you have done a good management, and the patient is fortunately recovering. But a lot of learning points, and some of the points will get answered only after a few years.
And I think Bangalore Ramakrishna Hospital, Dr. Ramakrishna, somebody have done almost 40-50 cases of EVTs, cases of EVT in posterior circulatory strokes. That video is there. I'll share you. He has shown very good improvement with EVT in lot of cases. He had achieved very good improvements. The same thing.
Has he done EVT in the isolated vertebral arteries also?
No, sir. Vertebrobasilar only. This is a vertebrobasilar, sir, actually, this case. Because there is
but there is no basilar artery occlusion. There is only vertebral artery occlusion. Basilar artery flow is good in this patient, your patient.
In the distal basilar, sir. But proximal, sir. Proximal basilar artery. Like I'll show you. Okay. In the
Manoj, you have any Manoj?
First scan you are telling, sir.
Yeah. Manoj, your comments on this case, you are an interventionalist. What would you do?
Sir, you are on mute, sir.
Sir, when the patient has worsened acutely, I would have gone and done the thrombectomy, sir, because the intention is to save the perforators and to avoid the perforator infarct at the level of the pons. The patient will be locked in otherwise. When the patient came, he was not locked in. He had a medial medullary with some paresis. But once he worsened, I think we should have
Immediately at
opened.
that time. Immediately
Yes.
at that time you would have, yeah.
Yes, if we would
Maybe
have
in the
had.
beginning you would not have intervened, you would have watched, but the
No.
moment he worsened, you would have intervened
Yes,
probably.
yes, sir. I would have not done for isolated vertebral ever, but there is something to be thought about the mechanism of stroke, sir. Patient looks little younger. Forgot the age. If there was any neck manipulation, then maybe we could have considered dissection. Dissection has a high rate of this thrombus propagation. It keeps throwing clots upwards, and even antiplatelets, thrombolysis are little dicey in that situation. But if it was an atherosclerotic stroke, then this propagation would not have been so much. In CT angio, we could have had a better idea of the mechanism of stroke, what might have happened.
The CT angio, I have just go through the CT angio, sir. This is the CT angio after deterioration, sir. We have not done initially. Only the
Okay.
MR angio we have done.
In this video, I'm actually not able to make out, madam. On the console,
yes.
if we can reconstruct and see,
Yes, yes,
probably.
yes. But
I also cannot see the vessels. I cannot see the vessels.
these are the reconstructed images, yeah.
Yes, madam. Vertebrobasilar
No, but-
junction is occluded with retrograde
No, but in
flow.
this you can hardly see any. Yeah, you can hardly see any basilar artery here.
Yes.
I mean, you can see only the middle. You can see only the upper part of basilar, but the
Yes.
middle part you can't see.
Yes, sir.
Yes,
This
sir.
point we should have probably opened.
We
that
could have
artery.
intervened.
Yes.
Yeah. So I think I think that is the learning point. That if
Sir.
there is a low NIHS at that time, probably we can wait. But patient is
Yes.
under observation. The moment they worsen, we should immediately go for
Yes,
EVT.
sir.
Probably.
Yes, sir. Yes, sir. Yes.
That's what all of us are saying.
Yes.
So any other comment, Manoj?
No, sir. That's all.
So Anita, thank you so much. I think you shared
Thank-
a very, very interesting, which is a very thought-provoking case. And I think in the future cases, probably this case
Sir,
will
just
remind us.
one query I also had, that if there was a floating thrombus in the vertebral or the ICA, what is the guideline says we have to thrombolize if patient comes in window less than 4.5 hours. But very frequently we see distal embolization for these floating thrombi. So what should we do? Any suggestion?
No, for floating thrombi, generally, if we are not thrombolizing, then heparin is usually given. Conventionally, heparin is the treatment, even as per the guideline for the
Yes.
thrombolized patients. But
If patient-
non-thrombolized patients. But for
Yes.
patients which are thrombolized, I don't think we can use heparin, but then tirofiban can be used.
Yes.
Tirofiban is allowed to be used after IV
Yes.
thrombolysis. And I think it's a very favorite drug of interventionalists. What do you
Yes.
say?
Even for this patient, we could have tried tirofiban when he worsened acutely.
Yes.
It would have
Yeah,
salvaged
yeah.
some tissue for us.
Okay, okay, sir. True, sir. Post 24 hours IV thrombolysis, I have started him on heparin, sir.
Yeah.
Along with the ecosprin.
Yeah.
Put him on heparin. I don't know. Luckily, he improved. Maybe thrombolysis might have helped.
Yeah.
Yeah.
So thank you very much, Anita. Great
Thank you.
case, and thank you,
very
Manoj.
much.
Both of
Thank
you
you.
presented great cases, food for thought, and very nice.
Thank you, sir.
Thank you.
Sir, there is one
Gennova.
audience, sir, if you allow.
Yeah. Please.
So the question is to Dr. Manoj. What is the role of intra-arterial thrombolysis in patients who have already received IV thrombolysis?
I don't know, madam. I don't know. If you have received the full dose of thrombolysis, I don't think you can give any more thrombolysis intra-arterially. It will most likely bleed.
Sure, sir. Thank you, sir.
Yeah. In fact, there is no role of intra-arterial thrombolysis as a standalone treatment.
Yes.
To be given those patients where mechanical thrombectomy has been done, then just to remove those small residual clots from the perforators, it's used, which Manoj has shown us.
Yes. And the
But
intra-arterial
no
dosage.
standalone
Intraarterial dose is very, very low, 2 to 3 mg, and should be given very carefully.
Yeah. So thank you very much. Over to Team Gennova.
Thank you, sir.
Supriya?
I would request Mr. Kutti to please give the vote of thanks.
Yeah. Good evening, sir. And on behalf of Gennova, hello, am I audible?
Yeah, Kutti, you are audible.
Sorry.
Yes.
Sorry, there was a network glitch. So, good evening and thank you, sir. And on behalf of Gennova and the entire team, it is a pleasure. Having you for this KT Live, which is a series of program, and we had a very good interaction today. So, thank you, Subhash Paul sir, for conducting this program, and speaker Dr. Manoj Vashi Reddy and Anita ma'am for a wonderful cases which present this and go during this weekend. So thank you all. Thank you for this session.
Thank you.
Thank you and good night.
Thank you, sir.
Thank you, sir.
Good night, sir.
Thank you, sir.